Dear colleagues, dear friends, this is Carlos Aparicio. I am participating today in this online event to celebrate with you the life of Dr. Masami Ando, who left us a few weeks ago. Masami was a pioneer in many different disciplines, and his practice was a flagship of modernity and patient care. As examples, he introduced for the first time computerized tomography in the operating room for better control of his surgeries, and also the innovative hyperbaric chamber in all his practices, just to speed up patient healing. Masami was also a leader in zygomatic implants. Actually, he founded the first Saga Center in Japan. I remember that at one phase we collaborate to determine a protocol consensus on the ideal implant trajectory in a quad situation. That was a multi-center study. So I wanted to have about 20 patients by center. He sent me 200 patients. And the paper was finally published in JOMI in 2022. I remember that he also surprised me by translating the first Saga book in Japanese. He spent a lot of time educating other colleagues in zygomatic implant rehabilitations and the Saga concept with his series of seminars at the ORC in Tokyo. More recently, Masami joined us for Edentulins 2023. He flew all the way from Japan. Actually, he stopped by in Barcelona, just to share his knowledge and obtain the recognition of the faster zygomatic surgeon in the world. I'm sure that all of us who knew him, we are equally impressed not only by the speed and quality of his zygoma surgeries, but also by his contagious sympathy and joviality. In his last days, he wrote me a farewell letter in which he told me that he had a stage 4 carcinoma, and that in few weeks he will go to heaven, using his own words. But he will be happy because he had known us. For my part, besides thanking him for the privilege of having him in this Saga family, I asked him to book me a chair in heaven next to him. In his last phase, he insisted on signing the Japanese Saga book as a gesture of gratitude to his friend Ophir Fromovic, who was able to join him in his parting. That makes me feel very humble and grateful. Masami was also an educator, teacher, and mentor for many of us. He trained the whole generation of clinicians in Japan and abroad. I believe Masami's commitment is an example for all of us. So I encourage you to remember him and use his love for life and his energy to improve our lives. They say that only those who are forgotten die. Masami lives on with us. That is why we have designed his educational webinar on zygomatic implants in his honor. To celebrate Masami's life, we are welcoming Dr. Takuma Ando, his son, Dr. Suminori Echisenja, Dr. Alex Fibichenko, and his good friend, Dr. Ofir Fromovic. We will share our experience in zygomatic implants, exposing a patient who has been special for us. And so we will say, see you soon, Tomasami. He will, as he will like, with a patient rehabilitated with zygomatic implants. Then I will begin this seminar with a presentation of a very, very special and personal case, my first ever patient for zygomatic implant rehabilitation. So this is Ignacio. This is the pre-surgical picture showing his open bite situation. At that time, Ignacio had 16 years, so he was very, very young. The patient was a little worried about the cross bite and the open bite. So he asked for a consultation, and they decided to perform an orthodontic surgery. So he got an osteotomy of the premaxilla that subsequently failed, leaving, well, let's allow Ignacio to tell the story for us.
How old were you at that time, and what happened?
I was 16.
16.
I think it was 1984. I have this kind of open bite
Okay.
in the part of this part, and they decided to make surgery in one of the hospitals of Barcelona at that time. But the surgery was not successful, and I lost all the bone, the anterior segment,
Okay.
with all the teeth. For me, it was a drama because
So you lose the anterior teeth,
yes,
your front teeth,
and the bone.
and you were 16 years old.
Yeah.
And also the bone. And then I think you have also another problem because you have a communication between the nose.
Yes, there was no bone. For example, when I was eating soup, the soup was coming through the nose.
Through the nose.
Then at that time, the chief of the Hospital de Belviche, Dr. Pericot, he was a famous maxillofacial surgeon. He didn't know what to do. They didn't want to put a huge prosthesis to close this, and they make a transplant of the skin just to try to solve a bit.
How old were you at that time?
Sorry for that. So this is the post-surgical picture after 1 month. So as you may see here, Ignacio loses the whole premaxilla from premolar to premolar. There was like a huge oral nose communication, as he said. This was 84. So he showed up in our office. 84, I think he showed up at the office in 85, like 1 year later. And we were very novel on regular implants. So when we saw him, we were like, oh, let's call our mentor, P.I. Branneman, and try to find out if we can do something. So you can see here the lateral view, all the premaxilla. It was a prognatic mandible, so it was a class 3 mandible with a skeletal defect, so it was even more augmented. So that's the frontal, the OPG, 84. Allow Ignacio to tell us a little bit more.
My mother was a hard woman, and she tried to look for a solution. She contacted Canada, Israel, and suddenly meet you and your colleague, Dr. Oliver, who had this knowledge of Dr. Brannemark. You put us in contact with Dr. Brannemark, and Dr. Branemark decided with Dr. Keller at that time was the chief of the maxillofacial department in the Mayo Clinic in Minnesota, in Minneapolis, I think.
Yeah, Minnesota. Yeah.
Minnesota. They decided to perform the surgery. The first stage was there were two surgeries. The first one to make this bone transplant, which was at that time was using the iliac crest.
Yeah, the fit, yeah.
They cut, but then they made this with these huge implants, and then there was a second stage where I don't remember, doctor. They put some kind of connection, and the third stage was at your clinic in Barcelona.
Yeah, and then you got some teeth.
Yeah. My mother.
So this was the trip of Ignacio. We were able to arrange the bureaucracy, and then the Social Security paid his travel to Gothenburg. P.I. Branemark didn't charge anything, and he was very lucky, as he said, because Eugene Keller from the Mayo Clinic was spending a sabbatic year in Gothenburg just to learn about regular implants. I'm not telling you about zygomatic implants here. Can you understand that? The chairman of the Mayo Clinic, of the maxillofacial department of the Mayo Clinic, spending one sabbatic year to learn how to place a regular implant in Gothenburg. So he was the one in charge of closing the soft tissues, to close the communication between the nose and the mouth. And so they took, that was the drawing of the defect, anterior defect, as you may see here. So the idea was to extract one more premolar. So, and then we used this, they took this part of the hip, the iliac crest, that was transfixed with those two implants that P.I. Branemark prepared himself on his office. And so this is the final result. As you may see here, this is the rehabilitation we place in his mouth. And maybe you can see here that we left the open bite, the initial open bite, because it was like an incompetence of his upper lip to close it. We finally were able to publish this report at the JOMI in '93. This is the prosthesis we placed. This was placed in Barcelona with my partner, Dr. Olive. We took the two premolars, we crowned the premolars, and we anchored the prosthesis in the two implants and on the premolars too. So this was 89. 89 is very far away. So let's, the time goes by, and let's Ignacio to explain a little bit more.
Can you tell us about your feelings when you recovered the denture?
My life changed. When I lost my teeth, I was 16. It was not just a problem. It was the bone. The bone was under necrosis. I feel like when you feel that something is spoiled, like a spoiled leg. During 1 year, I didn't want to go outside. When you are 16, these kind of things shock you a lot because you look at the mirror and you feel like a monster. Now it's different, but at that time it's affecting you and it affects my whole life. I cannot imagine if I was with that prosthesis that at the middle of the 80s they wanted to put in Barcelona, which was like a, you know this kind of things, they don't use anymore, but our mothers, they were using to put inside the shoe with the word in Spanish is horma.
Okay.
It was like that, but here on the mouth. But Dr. Branemark, can you change my life? Because, okay, it was a prophecy, but it was functional and aesthetic, and it was the first or the second. That means I know the medicine has changed a lot in this field.
Can you?
So this is the final reconstruction. As you may see here, we kept the open bite. Ignacio, as you have seen, he was very happy with this, and well, it's not the ideal, but it's something better than a removable denture with no retention at all. As I said, time flies, and I was thinking what patient I was going to introduce you today. So in a moment, I thought maybe I should call Ignacio, but it was almost impossible to find him. We tried on the social media, and we couldn't find him. And then suddenly, an idea came into my mind. So I called my old partner, and yes, my old partner was in contact with him, so I could rescue Ignacio and a part of his history. So Ignacio, I met Ignacio just a few days ago. He provided me with this OPG. So this is March 2021. As you may see here, Ignacio, with time, he lost the almost all the remaining teeth. He has big decays on the molar region. So now the two implants are supporting the anterior prosthesis. He has not anymore the premolars, has not the crowns that were diminishing the cantilever here. So this prosthesis, as you may understand, is under mechanical risk. This is October 2023, even worse because he lost this molar from here, and the other molar hasn't show up still. And at this time, Ignacio is telling us that he fell down with his mouth, and he felt that something happened.
I have an accident. I fall and with this glasses, you can see here, I hit my face. At the beginning, it seems that everything was okay in a famous hospital in Barcelona, Hospital Clinic, which is one of the best hospitals in Europe. They didn't detect, but my dentist, which were your former colleague, he has a lot of experience. And just opening a little bit, he said, something is wrong here. And then we realized that one of the implants was broken.
So now, on top of this, I think you lose some teeth on the upper jaw?
No, but because we have to realize that I think it's the first or the second time, I don't remember, this has been in my mouth since 1988. I have an...
So this is what we got from him 3 days ago, this Thursday. From the two implants, one is broken. So that's nice, is the power of osseointegration that has hold the implant until it's broken. I'm assuming that this implant, to me, wasn't, it breaks by fatigue, because there's so many masticatory cycles that at the end is. So this is the current situation now. You can see this is Ignacio's mouth. We have one implant and the other is up there. This is one remain of decay. So he has just one molar with this abrasion, because it's the only molar in the upper jaw. There's a big distance between the upper lip and the lower lip for sure, because it's a skeletal class 3. So then we have decided to use our SAGA social program. You remember we have what we call the SAGA Aid and the SAGA Learn. SAGA Aid is devoted for patients that have no resources. So for that is about patient application. So a patient having, as I said, no resources. We have a committee decision. This patient is introduced by a center, and in this case, the center is being the Saga Center of Stuttgart with Professors Peter Simon and Madeleine Simon. This is the planning for this patient that, as I said, is going to be introduced in this Saga Ed program. We will place 2 more zygoma implants, and I think in the left side we can place 2 regular implants, so I don't think we place 2 zygoma implants on the left side, but just 1 implant zygomatic on the left and 1 implant zygomatic on the right. So at the end we will get 2 implants, 2 zygoma implants on the right, and 1 zygoma implant on the left plus 2 regular implants. And with this, hopefully, we will provide him with immediate prosthesis. This is for the next future. Still, we haven't treated, as I told you. So this is the center who is going to be in charge of this. Is Saga Center Stuttgart with Professor Peter Simon and Professor Madalena Simon. As you know, to apply to this grant, you have to be a certified Saga Center. You have to introduce as a patient that really deserves this kind of free treatment. And for that, Saga Center's headquarters, we will provide you with the cost for reinforced provisional prosthesis, and Straumann will also provide with the material needed for the surgery. And with this, I thank all of you for being here and having made possible to provide this tribute to our common friend, Dr. Masami Ando. Thank you.
I'm honoured to be part of this tribute to our friend Masami. I was truly heartbroken to have to say goodbye to him. It was too soon and I already miss him immensely. He was really one of the good ones. Ando's professional achievements have been at the pinnacle of our industry. He was a pioneer in many ways and has influenced the thinking of many dentists and specialists throughout the world. But to me, he was much more than that. To me, he was a dear friend. Always supportive, always genuine, and always smiling. I first met him when he and his son Takuma came to my residency program. I think first it was back in 2016 and then again in 2018. I remember Masami showing me x-rays of the cases that he treated, zygoma cases, and he had so much experience, but he was always so humble and keen to learn new techniques. His achievements and drive to make his patients smile as wide as he used to smile have always been an inspiration to me as well as to many others. Our souls connected the minute we met, and Masami has always held a special place in my heart. I really loved and adored him. He literally rolled out the red carpet for me when I came to visit his clinic in Tokyo. But in reality, he was the one deserving of the red carpet. I will forever remember all the times we shared in Melbourne at my clinic, in Tokyo and Yokohama at his clinics that he founded, in Mykonos, of course, at the infamous Full Arch Summits in 2019 and 2022, and right up to having our last beer last December. He was adamant, even when he was already so unwell, that he wanted to be there in Mykonos at this year's summit. Sadly, he didn't make it, but he will be there not only in spirit, but through his son Takuma, who will make a presentation as a tribute to his dad's work and his legacy. Masami was an amazing surgeon, one who thought of the whole person, not just the teeth. He told me with a great deal of conviction that we will be reunited in heaven, and this gives me some solace. When he first told me he was dying, I was actually on my way to present at a PICO symposium in Florida, and I couldn't stop thinking about him throughout my lecture. So without further ado, I'm honoured to present a piece of that lecture as a tribute to my friend Masami.
Going back into techniques now, and I'm going to focus a little bit of time on zygoma. What puts people off zygoma? I know what put me off zygoma when I started to get into it back in 2010, 2011. What put me off Zygoma was the complications, the sinusitis, oroantral fistula, buccal dehiscence, and a concern for failure, although failure is not a big thing with Zygoma implants. They've got so much anchorage, it's rare to actually lose a Zygoma implant due to failure. The bigger issues were the sinusitis and the OAF or OAC, whatever you call it, and the buccal dehiscence. Now, what are the factors that cause this problem? If we look at the factors, implant design has a big role. An implant that has threads through the sinus, through the soft tissues, whether it's the sinus side or whether it's on the buccal side, an implant that has threads is already problematic. If you're going to have soft tissue, and sometimes the sinus is very, very thin tissue, if you're going to have that in contact with threads, what happens if you have a sinusitis, if you have an episode of some sort of cold or something like that, and you've got your sinuses are blocked, and you've got stuff in the side, there's no drainage, what's going to happen with the threads? They're going to exacerbate the problem. It's going to make it worse. And it could potentially also result in an oroantral fistula. So the implant design has a lot to do with the surgical complications that we used to have in the past. But also the surgical technique. The surgical technique also has a lot to do with it. And if you do a surgery where in the past, the original Zygoma protocol was to put the implant straight through the sinus, disregard the sinus membrane, and then anchor it into the cheekbone. So the main focus was to 2 points of anchorage, one in the palate and one in the cheekbone. But then that technique has led to a lot of problems. And one of the main problems is the restorative complications. You had a lack of restorative space because you wanted to preserve every bit of bone. And as a result of the lack of restorative space, you'd have breakages, you have difficulty cleaning, poor aesthetics sometimes. The aesthetics not a major problem, but the difficult cleaning and the breakages was a big issue. And the speech impediment. Patients who have implants on the palatal aspect find it difficult to talk as well. It's uncomfortable and it's difficult for them. And the surgical technique has a lot to do with that. So with this Zyga flat implant, I use Zyga flat and Zyga round in different types of situations. The technique that I decided to go with was one which I worked on skulls for many hours, different types of bone situations, and I tried to work out how can I get an implant in the right spot for the restorative aspect. The primary consideration for me is to have the implant in the right spot, so it's right, so it doesn't create this cantilever. And I decided that I have to go sometimes through the sinus, sometimes I don't, and sometimes it's halfway. So the grafting technique, there are different types of grafting techniques that I use, but typically I use a BIOS collagen in combination with what we call nanobone. And that bone, when I create the channel or the slot, when you put the bone there, there's a bony buffer. So even in the old type implants, I used to use it when the implants were threaded all the way up. That was particularly advantageous because it kept the sinus membrane away from the threads of the implant. But then I had an issue on the buccal aspect. I didn't want the threads exposed on the buccal. So I used to have to put the implant more deeper within the space, which means if it's deeper within the sinus space buccally, then you're going to have an issue that is going to be too palatal. So you have to put it deeper. And then you lose your stability at the crest. And then finish it off with soft tissue management like we do normally. And then you have a situation where you've got the implant positions is ideal. And after 24 months, you can't tell the difference which one is the Zygoma implant and which one is the standard implant. And this is what I want to achieve. Just because the surgical situation, the clinical situation is different, doesn't mean that the parameters for success changes. You want it to look the same. So this is an example of the bone grafting, and it's very common to have this amount of bone around the implants. You can see that it's the same case that I just showed, the 2 BLX implants and then 3 Zygoma implants. And that bony buffer is very important, because I think that even if you have an issue with the implant and you had to take it out for whatever reason, you have this buffer to enable you to work more safely next time around. It's your contingency plan. I use 4 different techniques. I use what we call a hockey stick technique, a slot technique, a sinus crush technique, and an extra maxillary technique. So the hockey stick technique essentially involves a hockey stick, right? Creating this shape where it allows you to visualize the sinus and also to visualize the trajectory into the zygoma bone. Most of what I rely on in terms of analyzing the zygoma bone clinically is done from inside. Using my elevators from the inside, I can feel the curvature of the zygoma bone. But obviously from the outside, it's sort of, especially when I started using these techniques, started doing zygoma, it's very advantageous to reflect the bigger flap. And if you reflect the bigger flap, you can see better, so you can learn what you're doing a lot better. But it does cause a lot more swelling and a lot more bruising. Whereas with this technique, with a less invasive technique, there's a lot less swelling and less bruising. So I use this hockey stick technique. I put some bone on the inside, and by putting the bone there, it kind of distalizes the content of the sinus membrane and everything away from where I'm working. And the material that I use is nanobone on top of Bios collagen. So Bios collagen, the reason I choose that is because it's very spongy, it's soft, and it holds together. It's not hard. Those qualities means that it's not going to damage my membrane because it's soft. It's like fluff. And then I put the nanobone on top of it, and the nanobone is firm. So it creates a firm bed over the soft graft, which allows me to do the instrumentation for the Zygoma implant. And the implant you need to get the points of stability here. This is where the main stability comes from. So the implant has to protrude through. If the implant doesn't protrude through, then you're basically relying on this bone, which sometimes can be quite poor. You get zygomas sometimes which are really thick and a really poor bone. And you think, oh, it's a zygoma, it should be hard, but no. It can be just like your jawbone, the zygoma bone can be very poor. Finishing it off with, with a multi-unit abutment, the graft, some PRF, and the same sort of technique, keeping some references. The references are then used to be able to convert the implants into the digital space and also to guide me in the best positions of the implants. And you can see the hockey stick technique, it enables me to graft quite well around the implant. So there is a lot of contingency with this technique. And it's my favorite, but not the most commonly used one, but it is my favorite technique. The next technique is the slot technique. So the slot technique involves obviously doing atraumatic surgery to try and preserve the membrane. And there are these beautiful VersaBurrs, which you're able to use in this situation, which you can use the tip of it to drill through and to create this slot. So you don't have to use a round drill to do that. Again, I use some bone grafting. So I isolate the sinus with the sinus tool, and I put a soft bone graft in there. And then I use the firm bed. The firm bed is the nanobone. And the nanobone allows me it just holds everything down, and I can then do the instrumentation and put the implant in and use the PRF on top. So the slot technique again, you can again build up some bone, but as you can see, it doesn't go as far forward because you haven't reflected as much of the sinus mucosa, so you don't have as much space. So it doesn't go as much forward. It's usually the bone is just around where the implant is. And When you look at this type of bone situation, this is what I was trying to say, is that the anatomy of the bone is not everything you look at. And you don't want to encounter poor bone at surgery. You want to be able to plan for it in advance. And this type of situation where you've got really, really poor bone density, this is something that you can plan for from the start. The good thing about this particular case is that it's got a really good piriform area, a really good spot to put to get better stability for the anterior implants. And here it is that I did a slot technique, and you can see the position of the back implants are ideal. It's where you want the implant to emerge. There's enough restorative space, and you've got a lot of stability in the front. And the reason I used the slot technique here is because I didn't have to be the shape. It's because of the shape of the lateral aspect of the maxilla. And I'll show you the indications for the slot technique versus the hockey stick technique in just a moment. For this particular patient, we were able also to do a dramatic change in her profile. You can see the change from where the teeth used to be, and then how we were able to bring that in. And typically, to do something like that with conservative treatment, even if the teeth were good enough and you could keep them, would be very difficult. And you would need to have orthognathic surgery, which would be fantastic if the teeth were sound. I want to share this sinus crush technique because this technique is really important in situations where a patient has no restorative space in the back and you have to have a procedure like this in order to get the restorative space. You can see the zygoma implant is not supported at all at the crest. Now, that is a problem because that means that you have to get excellent stability of the implant, and you have to make sure in this case that you have this rigid connection. This is where it will be extremely critical to have a rigid connection. But I finish it off in the same way with PRF with membranes. Now make the sound louder, please. Listen to the bone when you put it in. You can hear the implant going through the bone. One of the most amazing things about the Zaga invention, Carlos, thank you, is the mount, which is a beautiful narrow mount that allows you to position the implant where you want it. You're not hindered by a wider mount, and it also engages the implant a lot better.
Let's finish it off.
So I want to make sure it's in the right spot.
See how it's in the middle of the socket?
Yes, I saw that. And you started from like...
Good choice. Perfect choice. Okay, now give me a...
See, it's getting very solid.
That's how, there we are. What do you think?
Almost there.
Pretty good there.
It's actually really good.
Yep. See how it's all open around it.
Okay. Yeah. Yep.
So this is all.
Okay, so it's not supported by the crestal bone. So this is one patient that had a sinus crush, and the reason he had it is because you know, when he smiles, you could see all the way back to his gums, and the amount of alveolectomy that you need to do in this case is huge. And he's got an open bite, so he's presented with an open bite. We actually need to close the occlusal vertical dimension and manage the gum display at the same time. So the first thing I did was I tried to get to the right vertical. That's always the most important thing to do, is get to the right vertical. So I cut back the teeth in order to close his bite so he gets into the right spot. And you see on the left side is where he was to start with, and then on the right side is where I closed this bite. And these are his zygoma implants. You see there is no bone support there whatsoever. His gum line and the tooth position and the final teeth position. You can see by comparison to the original gum line where it is. He's got plenty of restorative space now. Very nice and easy to clean. This is a week after surgery. And there he is. So it's important in those cases, you can really create a big problem if you don't have enough alveolectomy. In a case like this, if you didn't do a sinus crush, you would be stuck, you would be limited within the bone, and there is no bone in the back. So you're going to struggle. You're going to see a transition line, and you're going to be really struggling with the restorative space to get a proper restoration. And this is obviously not just the aesthetics, but it's also cleanable. On the inside, it's very thin, so it's very easy to keep clean. This is an extramaxillary technique. So this is a quad zygoma. That's why I use the pterygoid. And notice that I use the zygoma precision drill for the pterygoids. It's much easier to use than to try and use a contra-angle handpiece. Because you go with the zygoma, the axis is much easier. It makes a lot more sense. And I don't use a guide usually. I'm typically anti-guide, but sometimes I do it for fun. And I think a guide with pterygoids and also a guide with zygomas is the wrong choice, because the point of anchorage is so far away. If there is any distortion whatsoever in the guide positioning, it will intensify on the side where the anchorage point is.
We took for granted.
You can make it a bit louder if you like.
We've lost dancing.
So this is the extramaxillary. I still lift the sinus and push it all away. This is my contingency. I want to push the soft tissues away from my implant.
We've lost dancing.
See where the water is? The water is on the drill, and I go in and out, not just once in until it burns the inside. You have to come out, let the tip of the drill cool down sufficiently before you go back in again. It's the basics of implantology that you have to use here as well. This is the precision drill with the Versa kit. So the Versa's got a cutting tip, and it's also got a side cutting as well. And I only use it in reverse. I don't use it I only use it forward. In the zygoma area, I only use it forward, never in reverse, because I don't want it to burn the bone, although these drills do have internal irrigation as well, which you can use.
Dancing. We've lost the hugs with friends and people that we loved. All these things that.
The position is critical. That's always what I aim for, is to make sure that the implants are right in a spot-on position. This side was a little bit more of an issue for me. I had a small perforation.
Day by day. We've lost dancing. If I can live through this.
The PRF membrane is something that's very nice to use because it can be exposed on the outside or on the inside. But where I'm putting the bone graft is not in the area where I have the tear, right? So the tear is higher up. I'm putting the bone graft further deeper in so that I've got more space to drill. I don't like using bone graft if you have a big tear. So it has to be fully encased. You see the concavity of the maxilla here. This one is more extramaxillary. Finishing it off in the same way, managing the soft tissue, making sure it's all passive, adapt. Sometimes you need to create some additional incisions to make it passive. This bone graft I use just on the inside aspect of the implant. So I never put a bone graft on top of the implant, but when it's contained between the bone and the labial aspect of the maxilla, I do use it, and then I use a membrane on top of it. Sorry. Oh well, we'll go to the next one. So the extramaxillary technique sometimes is very extramaxillary, and in those situations I would consider a fat graft. And a fat graft is not something I would routinely do because it's always something that I want to potentially have contingency in the future. Maybe I don't need a fat graft over this particular implant, so why use it? Sometimes it just pops out and it's so, you feel like, oh, well, it's there, let's use it. But you want to keep that contingency because in the future, if you have a problem, you want to be able to access that fat. And if you use it now, you won't be able to access it later. So this is a patient with very little bone. The implants are positioned, good anchorage, PRF, and then the fat graft on top. Again, not something I would routinely use. 5 implants.
Let's welcome now Dr. Suminori Chisenya from Saga Center Hokkaido in the north of Japan to talk a bit about Dr. Masami Ando, say goodbye and understand your words, what you want to tell him. So we're going to start with, how you first met Dr. Masami Ando. Can you tell us a bit about this?
Yeah. まずはじめに、偉大な安藤先生の追悼ウェビナーに参加させていただき、とても光栄に思います。また、このような機会を与えてくださったアパラチオ先生、オフィア先生、アレックス先生、デビッドさんをはじめ、関係各所の皆様に深く感謝いたします。私が安藤先生と出会ったのは、2009年 USC ジャパンプログラムでした。安藤先生は前の席に座っておりまして、授業が終わると振り返り、満面の笑みで楽しそうにインプラント談義を始められたんです。その瞬間、強烈なインスピレーションを感じたのをはっきり覚えています。
So from that moment on, your first encounter, how did your relationship with Masami evolve?
ISO というスタディグループを通じて交流を深めていきました。特に記憶に残っているのは、オーロン4セミナーでの安藤先生の主義です。その速さと確実性には正直驚かされました。また、ザイゴマインプラントについて相談したとき、親身になって真剣に話を聞いてくれたことも忘れられません。
All right, a lot of implants, I guess, but how was your time with Dr. Ando like?
先生はハワイが好きで、気さくで、とっても親しみやすい方でした。スーパーカーとかクルーザーをこよなく愛する夢のようなライフスタイルは、僕らに夢と希望を与えてくれました。趣味のスーパーカーやクルーザーで憧れのライフスタイルを見せてくれた先生。その夢のような生活は我々にとって大きな魅力であり、希望の源でした。ハワイやミコノスでの自由気ままな姿は、仕事の緊張から解放される貴重な時間となりました。
Yes, a lot of free spirit and hard work and smiles. Can you tell us a bit about Masami's accomplishments in the profession?
末期の肺がんと診断されながらも、ザイゴマインプラントへの揺るぎない信念を持ち、世間のザイゴマに対する当時の逆風にも負けず、この分野を開拓し続けた安藤先生。その勇気と決断力は、私たちに大きな影響を与えてくれました。特に、ミコノスサミットでの講演は、先生の技術と情熱が世界に認められた瞬間でした。ドクター・オフェアに、ザイゴマ・フェラーリと呼ばれたのもこの時です。
Yes, indeed, the Zygoma Ferrari, the fastest Zygoma surgeon in the world, I guess. What is your last memory of Masami?
去年の9月のことなんですけど、私一人でハワイに行ったんですよ。で、帰りの便で安藤先生から連絡来たんです。で、どこに行ってたのって聞かれたので、ハワイに行ってましたと伝えると、なんだ、行ってくれたらよかったのに。僕も一緒に行きたかった。で、大先輩の安藤先生がとっても残念そうに言ってくれたんです。僕は正直、その瞬間泣きそうになっちゃいました。私こそ一緒に行きたかったです。安藤先生。こんなに大先輩なのに、まるで僕を友達のように接してくれて、ものすごく嬉しかったんです。その1週間後、安藤先生から一通のメールが来たんです。その内容は、とてもシリアスな話をしなくてはなりません。という言葉から始まりました。その時初めて僕は安藤先生が末期の肺がんであることを知ったんです。これが一生忘れられない安藤先生との最後の思い出です。あと、実は不思議な夢を見たんです。誰かがコーナーで、交差点で車をドリフトさせているので、僕は後部座席に座っていて必死に止めようとドライバーに呼びかけるんです。でも振り向いてくれないんです。返事もしてくれません。目を覚ましたのは1月17日午前6時30分。安藤先生が亡くなった瞬間、その時間でした。その後、僕は普段車好きなんですけど、全然車の夢なんか見たことないんですけど、毎晩見るようになりました。車好きだった安藤先生が僕に何か伝えたかったのかという疑問が残りました。夢の中の車が安藤先生からのメッセージなのではないかと考えると、その意味を探ることがもしかしたら私の使命であるかのようにも思いました。最後、お葬式の日、安藤先生のご遺体を火葬場まで運ぶ霊柩車の扉が閉まる瞬間、なんと安藤先生の声が聞こえたんです。またね、次はハワイで、と。
Do you want to leave a message to Dr. Ando?
安藤先生との出会い、そして一緒にいてくれた時間、本当に全てに感謝してます。だからこそ、安藤先生の意思を継ぎ、ザイゴマインプラントの分野で我々が貢献していくことが私たちの使命であり、それが安藤先生の何よりもの恩返しになると信じています。そしてこれを必ず実現させます。安藤先生の意思は永遠に僕たちの心の中の宝物であり、原動力です。なので安藤先生の意思は永遠に僕たちの心の中で躍動し続けます。安藤先生にはさようならっていう言葉って似合わないんです。だから最後はこの言葉で締めくくりたいと思います。安藤先生、それではまたハワイで本当にありがとうございました。
Thank you, Doctor. We will now move on to a case presentation, I think aligned with Masami's commitment to sharing everything he knows to the profession, especially the zygomatic implants, the Zygoma Ferrari. So we will present the case now that is special to you, also for the audience to learn more about zygomatic implants and honor Masami's leaving from this world.
Yeah, thank you. ザガセンター札幌の代表の 越前と申します。本日はこれから2例のケースプレゼンテーションをさせていただきたいと思います。拙い症例ですが、よろしくお願いいたします。まず、ザガセンターのロケーションを説明させていただきたいと思います。日本にはザガセンターが2件あり、安藤先生のいらっしゃる、ザガセンター東京と我々のいる北海道、日本の北端にあるんです。北の端ですね。そこの、一番大きな、都市である札幌というところで我々のオフィスは位置しております。僕のホームタウンは、実はふるさとはクッチャンというところで、皆さんご存知の方もいらっしゃると思うんですけど、ニセコという、今はスーパーリゾートになっちゃったんですけども、看板がもう日本語じゃなくて英語です。で、コンドミニアムもものすごい高級で、一度もし日本にいらっしゃったら、東京、大阪、京都もそうなんですけど、ぜひニセコにいらっしゃってください。もう驚くようなスーパーリゾートですので、向こうに見えるのがですね、富士山と勘違いされる方いらっしゃると思うんですけど、マウント富士じゃなくてマウントヨーテです。で、私は小さな頃、競技スキーをやっておりまして、スラローム、ジャイアントスラローム、ダウンヒル、3種混合でやってたんですけど、もう本当にね、スキーの街です。で、今はですね、もうあの頃はものすごくもう本当にど田舎の街だったんですけど、今は開拓が進んじゃって、なんとですね、私の実家、小さなお店をやってたんですけども、そこの、実家の土地がですね、4年連続地価高騰率日本一になりました。で、その当時私このね、土地買ってればね、今頃本当に億万長者だったんですけど、見事に買ってなく、買えばよかったなと、後悔はしてませんけど、いい経験させていただきました。ぜひいらっしゃってください。とってもいい街なので。じゃあ早速ですね、ケースの方、紹介させていただきたいと思います。まず1症例目なんですけども、非常に骨の状態がシビアな患者さんでした。具体的に言うと、胸骨、ザイゴマをやる上でちょっとシビアだった症例でしたので、ご紹介させていただきます。早速、紹介していきますね。で、この患者さんですね、見た目非常に美しい、女性の方、年齢は70歳なんですけどね、非常に若くお見えになられまして、以前もすでに、旦那さんが、上下オロン4当院でやられておりまして、旦那さんが日本刀を趣味としておりまして、日本刀を教えてらっしゃいます。で、さすが武士道の精神がありまして、もともと60本から90本ぐらいタバコを吸ってて、ヘビースモーカーだったんですけど、スーパーヘビースモーカーだったんですけど、僕が、インプラントやるんだったらやめてくださいと言ったら、もうピシッと、ね、一切やめていただきまして、もう0本だけではなくて、プラグコントロールレコードもですね、ほぼほぼ1桁ぐらいに、完璧なハイジーンなので、当然結果もいいんですけど、えらい喜んじゃってですね、それで奥さんをぜひ連れてくるよということで、ご紹介していただきました。で、主訴は、なんと、このご夫妻、いわゆる富裕層の方なんですけども、なんとこの方、入れ歯を使ってらっしゃったんですよね。ただやっぱり長いこと入れ歯を使ってたみたいで、どこの歯医者さんに行ってもちょっとできないっていうようなことを言われて、で、当院に紹介していただきました。で、口元がこんな寂しいんです。はい。もう全然富裕層に似合わなく、入れ歯を外したら、もう自信を失っちゃうと、典型的なね、こういう願望でした。で、骨の状態はね、これ一見ね、顎底があるようには見えるんですけども、後でコンビーム CT 見てみますけども、骨質も悪くて薄くて、さすがにこれはちょっと即時固定はできないだろうなと思われるような症例でした。これがですね、これは、日本製の吉田のファインキューブっていう CT で撮影したものなんですけども、このスティックネスって書いてるところですね、骨の厚み、具体的に言うと、必須骨の厚みが、これ、上顎同底で 0.6、なんと鼻腔底で、この位置だとね、もっと普通硬くて厚いんですけど、0.5 ミリぐらいしかなくて、驚くべきことに、口外側の骨も 0.5 ミリぐらいしかありませんでした。 で、歯槽骨の高さはあるんですが、幅がやはり4ミリ弱で、どうしてもここの位置だと、イミデートローディングが厳しいと。全体的には D5、ハンスフィールドユニットですと、0から100くらいですね。で、僕の経験上、鼻腔底の骨がだいたい1ミリ以上あれば、1ミリあればですね、だいたい 50% 以上、2ミリあれば 100%、45ニュートン以上は行くんですけども、0.5 ミリだとちょっと厳しいだろうなということで、ザイゴマを検討させていただきました。で、こちらがですね、ザイゴマの骨の診断です。で、CT でこう計測してみたところ、ザイゴマの厚みが 5.11 ミリですね。で、これ、ノーベルのインプラントだったので、直径が4ミリなので、だとすると、骨が 1.1 ミリぐらいしか残らないので、かなりシビアです。0.2 ミリはずれられないなというところで、ジャストの位置で入れなくちゃいけない症例でした。じゃあ次の画像を見ていきます。これ、私のところハイブリッドオペ室がありまして、で、ツイストドリルまで終わったところで、一旦トライインを行いました。で、トライインを行って、これで術中で一回 CT を撮影させていただいて、0.2 ミリは絶対ずれられないので、隣にコンビーム CT がありましたね。ドーム型 CT がありましたので、そこで撮影させていただいて、これがね、アフタートリートメントですね。術後です。で、両方ともね、左右ともに正確な位置に、0.2 ミリのずれ、0.1 ミリぐらい、ジャストの位置に入りましたので、ザイゴマを適用させていただきました。で、前方にはですね、極力骨があれば、極力多くのインプラントを入れるように心がけております。で、本症例では、2本ずつ、左右に2本ずつ、合計4本のインプラントを前方に入れてあります。で、これがですね、右の5番ですね、座が3です。で、計測してみたところ、5.45 ミリなので、先ほど 5.11 ですが、0.3 ぐらい幅が広がってるんです。これは、やはりちょっと、ドリリングもそうなんですが、ここまで薄いとなると、埋入の時にかなり気を使わないと、クラックが入ってしまいまして、骨が裂けてしまうんですね。よく安藤先生が言ってね、狭窄に裂けたらもうどうしようもないと。だから慎重に埋入を行いまして、もちろん、ゆっくり入れるのもそうなんですけども、亀裂正直これ入ってきましたけど、それをコントロールしながら、力の加え方とか工夫しながら、絶妙なバランスで入れることができました。で、プラットフォームの位置もですね、強固に、口外側に当てることができましたので、固定も非常に高く、がっちりとしております。で、ちょっと、これがですね、ファイナルの状態ですけども、これ動画あるんですね。実際ね、これちょっとモザイク入ってますけども、本当はね、メモを見せていただければ非常に喜んでいただいてですね、もうやはり今までコンプレックスだったんですよね。もっと早くやっとけばよかったってね、信じられないみたいな感じで、喜んでいただきました。で、こちら、術前術後の側房の状態なんですけど、左見ていただくとですね、やっぱり微心角ですね。ここがかなりきつくてですね、いかにもちょっと失礼ですけどね、おばあちゃんのような願望なんですけど、右の画像がね、もう、あたかも西洋人のような側房になりまして、もういかにも美しい、ね、日本人はやっぱり西洋人に願望にね、憧れがありますので、このようなスッキリとした顔を行います。ね。ナーゾラビアルアングルは86度、67度、約20度ぐらいね、改善しました。日本人の平均値が約105プラスマイナス8なので、かなり近づきましたね。本人がこのぐらいが一番いいと、本人の希望をもとに作成させていただきました。で、こちらがですね、正面棒なんですけど、横に並べてみるとですね、左の後額ですね、もともとやっぱり70まで左髪の癖があったんでしょうね、やっぱり。こういった体壁については、なかなか治らないので、とりあえず、光合力が上がったことがすぐに見て取れると思います。興味深かったのが、どんどんですね、体軸が整ってきております。で、これ、肩の位置もですね、右の肩の位置が大きく下がってきまして、左が逆に上がって、左右、バランスが整ってくれます。 うちにあるね、グラビコーダーでも結構重心も正しい位置に戻ってきたので、かなりいい感じじゃないかと。今、経過見てるところです。はい。じゃあ、1症例目終わったので、次が2症例目ですね。2症例目はですね、これはエナメル上皮腫の疑いがあった患者さんで、結構大規模な骨破壊がありましたので、ちょっと紹介させていただきます。で、この患者さんはですね、まず若い患者さん、36歳、なんと36歳の患者さんなんですけど、ランパントガリエスがありまして、職業は漁師さんです。で、我々の札幌から車で4時間から6時間ぐらいかかるところ、6時間かかるところからですね、わざわざ来ていただきまして、相当悩んでおりまして、願望、心微面、そして、もちろん、臼歯目、歯がないので、噛むこともままならなく、相当なコンプレックスを抱えておりました。で、なんとかしたいと。で、オール4を決意されていらっしゃっていただきました。で、これが実践の状態です。上下ともにランパントカリスが激しくてですね、本当に貧相なお顔でいらっしゃったんですけど、これが洗面棒ですけど、ガミの状態で、全然歯医者さんも行ってなかったんだろうなということで、遠方ということもあって、即日での、補鉄を希望されておりまして、で、オール4をやっていくという運びになりました。ところがですね、CT を見てきたときに、驚くべき状態が発覚しました。これ、科学が終わってから撮影したものなんですけどですね、こちらですね、ちょっと動画で見ていただきます。右の1番から5番にかけてですね、こちらを見てください。ね、このようにですね、中が空洞で、先ほどの患者さんと同じようにですね、皮質骨の厚みがほとんどなく、こちらは 0.3 ミリぐらいですね。ほぼないです。ですから、左の、右の1番から5番にかけてはほぼ入れられない状態で、もう始祖骨を使うことは全くできませんでした。なので、切開をすると、斑根形成するので、なかなか、治癒も悪いことから、エナメル上皮腫用の疑いの、腫瘍、農法を取って、と同時に入れれるところにインプラントを入れようという計画でした。これが断面図なんですけど、サジタル像ですけど、ご覧のように 0.1 ミリ、0.3 ミリ、0.2 ミリと使い物にならない骨で幅も広くて最悪の状況です。で、こちらがですね、左の3番のところなんですけども、こちらはですね、上顎道の前壁が発達しておりまして、空洞だったので、ここはトランスサイナスを計画しました。で、これがですね、右のそのエナメル上皮腫、疑いのところですね。エナメル上皮腫の処置は、切除療法と保存療法ってありますけども、もう感染してダメなところはね、撤去しましたけども、できる限り、年齢も若いということもあって、保存してあげたいなということで慎重に取っていきました。できる限り1回に取りたかったんですが、かなり大きな農法でして、やっぱり、鼻腔底までつながってたんで、そこをね、裂いていきましたんで、断片的に取りまして、どんどん取っていって、アンダーカットのところはですね、このように拡大形成して、これが鼻腔ですね。全部穴開いてました。で、さすがにこういったところはね、病理の組織検査を待って、本当は埋入したかったので、そういう設備はちょっとね、うちでもありませんので、とりあえずここは埋入せず、ね、入れるところだけ入れました。で、こちらはトランスサイナスのところですね。トランスサイナスで左のトランスサイナスですが、これ前に終わりまして、で、右の最後回って、ここですね。ここはもう置きました。で、この術後の状態ですけども、両最後まで、ここ左の1番と右の5番までかなり空いてしまったので、メタルフレームでね、これはプロビジョナルを固定することによって保護圧を分散させて、一旦ここのエナメル上皮腫瘍、結局病理の結果はですね、良性の農法だということで、ちょっと病理の先生もびっくりされておりましたけど、良性だったので、今後ちょっとここの治癒を待って、移植と同時にインプラントを入れていきたいと思います。在庫も予定しております。で、こちらが骨の破壊像なんですけどですね、これが今度は右の5番の在庫、座側ですね、完全に。これはコンケーブの状態でしたので、座側になっております。で、次が左の在庫ですね。こちらもそうですね、座側です。で、これが、プロビジョナルで入って、この状態でも非常に喜んでくれてるんですよね。大変喜んでおります。 で、やっぱり漁師さんということで、ちょっと清掃性にも不安があったので、下わざとちょっと利定型で様子を見ております。で非常に経過は良好です。で、こちらの赤ワインなんですけど、実は11年前に僕は本気で在庫米に取り組もうと思って、ノーベル以外のメーカーに止められて、あと大学病院の口腔外科の先生にも在庫米は絶対やめろと言われて、でもそれでもやろうと思って僕の友人で在庫米やってる先生がいて、その先生に相談したら、在庫米やってもいいけど友達なくすよっていうふうに言われて、僕が一旦ちょっとたじろいでやめちゃったんです。でも安藤先生だけが応援してくれて、この時いただいたワイン、今でも思い出です。2009年赤ワイン、Welcome to 在庫米ワールド。ね。で、これは僕の印象的な安藤先生とのミコノスの発表の海外講演の、ワンショットですけども、その時、これ、印象的な言葉がございまして、安藤先生が他の先生の Facebook に上げてた言葉でね、理想の歯医者を思い浮かべなさい。そしてそのように振る舞いなさい。本当に安藤先生には大変勉強になりました。本当に心から尊敬する先生です。先生のようになれるように今後も努力したいと思います。本日はご清聴ありがとうございました。
はじめまして、私は安藤拓馬です。まずはじめに、父の追悼のために素晴らしい機会を用意してくださったカルロス先生、オピア先生に深くお礼をいたします。私は卒業して13年のキャリアになります。父とは同じ職場で12年以上共に働いてきました。その間に共に行った在庫米手術は年間1000症例以上になるかと思います。2017年に父は肺がんを発見され、余命は1年と伝えられました。残りの寿命を意識する中で、双方に技術を継承するための覚悟がありました。2020年にザガセンターに加えさせていただき、多くの海外での講演する機会を与えられ、父は寿命の続く限り精力的に活動を行ってきました。世界中の多くの素晴らしい在庫米インプラントのプロフェッショナルと知り合い、ディスカッションできたことは運命であり、父にとって最大の幸運だったのではないでしょうか。死にゆく寸前まで世界中の友人たちと共に過ごせたことを嬉しそうに語っていました。日本国内においても2017年に太平洋に面した研修センターを開設し、日本やアジアの歯科医師に対して在庫米研修を積極的に行い、在庫米インプラントの認知や正しい知識の普及に貢献しました。現在、日本国内において在庫米を行う歯科医師の数は世界的に見ても非常に多いのではないかと思います。しかし、父にとって在庫米治療は常に順風満帆ではありませんでした。在庫米インプラントを始めた2006年当初、日本国内は在庫米治療に対して非常に否定的でした。それは、ザガゼロをはじめとする在庫米のオリジナルプロトコルによる弊害が大きかったのではないでしょうか。父は多くのトラブルを経験しながらも、この治療の有用性を信じて諦めずに技術の改良を続けていきました。私自身、在庫米に触れたばかりの頃は、そんなトラブルから治療法に対して疑念があったのは事実です。父は2004年にポルトガルのパウロ・マロからオールオン4コンセプトを学びます。2003年以前もフルアーチは手掛けていましたが、グラフト併用の垂直埋入によるもので、患者の時間的、身体的負担は大きかったです。2010年頃になると、オールオン4コンセプトによる即時機能が主流でしたが、依然、インプラントの本数が多かったのが事実です。2015年にドクター・アレックスとの出会いにより、リダクションの重要性を理解して以降、4本での治療が増えていきました。2017年以降は、在庫米の本数も増え続け、年間200本以上を手掛けるようになりました。2020年にザガセンターメンバーに加入させていただいてからは、さらに症例を増やしています。父 とは在ゴマ治療をさらに発展させるために、日々様々なアイデアを出し合い、ディスカッションしてきましたが、中でも最大の転機となったのは、オリジナルのドリルキットの開発です。このキットの登場によって、在ゴマを行う際に一番難易度が高かった在ゴマスロットの形成と胸骨上顎動側のパーフォレーションが非常に容易となりました。この画像におけるプレシジョンバーとデンサーバーの活用により、手術のスピードは一気に向上することとなります。在ゴマ治療はそれぞれの歯科医師に独特の主義があると思いますが、我々が日常的に行うオリジナルプロトコルを解説させてください。まずは切開ラインです。在ゴマの基本的な切開ラインをベースとしています。その後、全学的に剥離を行って口外の歯肉を縫合します。胸骨の剥離を行っていきます。おおよそ半分まで剥離ができると、それ以上先には局所麻酔が効いてませんので、麻酔の追加を行います。さらに剥離を追加していき、胸骨の基支部、後筋の付着部位を確認します。胸骨の中央部分と軸図を、連続したマーキングでシミュレーションを行います。上顎道を先行する部位にマーキングを行い、この部位に対してラウンドバーを用いて先行します。このような小さなウィンドウを作りまして、そこへコラーゲンメンブレンを挿入し、サイナスのメンブレンを挙上していきます。その後にデンサーバーを用いて、在ゴマスロットの形成を始めます。歯槽長にセットしたジックズを目指して設計を続けていきます。ジックズにデンサーバーを沿わせながら在ゴマインプラントの方向性を確認しイメージしていきます。これがスロットを形成した後の状態です。サイナスメンブレンが全く傷ついていないことが確認できます。その後にですね、プレシジョンバーで胸骨内面にドリルの基支部を形成します。ドリルにて在ゴマインプラント化を形成していきます。この時にはオーバーヒートを避けるため、注水を意識的に行います。加えてドリルの回転数を極力低回転にして、胸骨へのダメージを避けるようにしています。ドリルをさらに進めて、歯槽長から全体の在ゴマインプラントの長さを計測していきます。そして、近年では主にザガフラットを使用していますが、ザガフラットの埋入をしていきます。このプロトコルを用いることで、以前は1本の在ゴマの埋入に20分以上の時間がかかっていましたが、それが5分ほどに短縮されました。2024年になってから埋入した在ゴマたちです。非常にシンプルでスムーズなワークフローは安定的により多くの症例を行うことを可能としました。在ゴマに対するかつての複雑さはもうありません。父と私は時間があれば共通の趣味である車か在ゴマの話ばかりをしていた気がします。2人にとっては一番興味があり楽しい話題でした。在ゴマ治療は私たちにとって生涯興味を持って探求できるものの一つであったことは確かです。しかし、その根本には患者さんの負担を軽減するために、よりシンプルでよりスピーディーな術式を追い求め続けていました。しかし、同時に多くのトラブルとの戦いとトラベルシューティングの連続でもありました。在ゴマインプラントの感染や形成時のオーバーヒートにより、胸部に膿瘍を形成してしまい、形成外科とのコラボレーションをした症例も経験があります。こちらの症例のように膿瘍が自壊する寸前に感染した在ゴマを撤去することができたケースもあります。このケースでは上顎動側からの感染が強く見られました。さらに近年では ノーベルのタイユナイトザイゴマインプラントが胸骨内において破切することを経験したこともあります。この症例は化学前突のスケレタルクラス3で小さな AP スプレッドの上、上顎の治療のみであったため、力学的に破綻したものと考えています。後方のザイゴマは再度行うことは困難なため、AP スプレッドの確保のためには、テリゴイドインプラントの併用を行い、リカバリーをしました。これからご説明させていただくケースは、私たちの中で特に記憶に残っているケースの一つです。こちらが最初に患者さんがいらした時の2006年に父が2症例目のザイゴマ治療を行ったケースです。現在の基準では特段難しいケースではありませんでしたが、その当時は状況が全く違います。CT データによって光樹脂の 3D モデルを制作し、入念なシミュレーションを行いました。口腔内から現在のシガを除去すると、日本オリジナルのインプラントも除去することになりました。当時のノーベルバイオケアのドリルプロトコルでは、ドリルサイドにも刃がついていたこともあり、スロット形成の途中で上顎動壁を損傷してしまいました。ザイゴマインプラントを埋入することは何とかできましたが、実屈付近に大きな骨の欠損が生じてしまいました。これが術後のパノラミックと口腔内の状態です。数ヶ月後に患者は胸部の腫れを訴えて来院しました。今日の主張している部位を選出すると内容物に脳汁が確認できます。口腔内を見ると上顎道との間に大きな交通が確認できました。当時は初期の対応としてプロビジョナルにドレーンを設置し、このような感じですね。日々の生活において患者さん自身で洗浄できるような形態としました。このように洗浄をしてもらった経緯があります。そしてファイナルの補填では、交通部を塞ぐような形態を付与して穴を直接塞ぎに行っていたことがあります。数年間の経過において上顎道の交通部は少しずつ小さくなりましたが、患者は変わらず液体の交通と上顎道炎を訴え続けます。化学死から自覚骨を採取して移植を試みたこともありました。歯肉を再縫合したりですとか、フラップの移動を行ったこともありましたが、どれも良好な結果を得ることはできませんでした。最終的には2021年にザガセンターからの情報で得たバッカルファットを用いることで、長期間の経過の中で初めて上顎道との交通を塞ぐことに成功しました。とても長い治療経過と繰り返しの手術に我々を信頼してついてきてくれた患者さんには感謝しなければなりません。ザイゴマ治療は従来のサイナスグラフトやその他の選択肢に対していくつもの優位性があり、多くの患者の人生を変え、笑顔と健康を与えられる手法です。この笑顔を見るために、日々より研鑽し、難しい症例にアプローチしているのだと思います。彼らの喜びは私たちに勇気と自信を与えてくれます。それは同時に私たちにとって一番の宝物です。私たちにとってザイゴマ治療とは何なんでしょう。それはただ難しい治療に対する挑戦ではなく、私たちにとって大切な人の人生を救うために神が与えてくれた素晴らしい技術です。そして父が私に教えてくれたことは、覚悟と誠意を持って最後まで困難に立ち向かうこと。父から引き継いだ意思を生かして、これからも一人でも多くの患者を救い、一人でも多くの歯科医師に正しい知識と技術の復旧のために尽力していこうと考えています。最後に、父が闘病中、ドクター・アレックスに招待いただいた2019年のミコノス島で行われたフルアーチインプラントサミットに参加することを強く希望していました。あの時は 幸運にも2022年に2度目のチャンスが巡ってくるとは思ってもいませんでした。当時の記憶では父が一番輝いていた時のものです。父の死後、父の友人たちからいつも笑顔を絶やさない人であったという話ばかりを聞きました。本当にそういう人だったと思います。在庫間のトラブルであろうが、その解決を嬉しそうに楽しむような歯科医師でした。そんな父が大切にしていた思い出のスライドショーを彼のプレゼンテーションから借りてきました。このビデオを見ながらお別れをしたいと思います。
I took the supermarket flyers from the windowsill. I threw the day-old tea from the cup. Packed up the photo album Matthew had made. Memories of a life that's been loved. Took the get-well-soon cars and stuffed animals. Poured the old ginger beer down the sink. Dad always told me, don't you cry when you're down. But Mum, there's a tear every time that I blink. Oh, I'm in pieces, it's tearing me up. But I know a heart that's broke is a heart that's been loved. So I'll sing hallelujah. You were an angel in the shape of my mom. When I fell down, you'd be there holding me up. Spread your wings as you go. And when God takes you back, He'll say, hallelujah, you're home. Fluffed the pillows, made the bed, stacked the chairs up. Folded your nightgowns neatly in a case. John said he'd drive, then put his hand on my cheek and wiped a tear from the side of my face. And I hope that I see the world as you did, 'cause I know a life with love is a life that's been lived. So I'll sing hallelujah. You were an angel in the shape of my mom. When I fell down, you'd be there holding me up. Spread your wings as you go. And when God takes you back, He'll say hallelujah, you're home. Hallelujah. You were an angel in the shape of my mom. You got to see the person I have become. Spread your wings and I know that when God took you back, He said hallelujah, you're home.
ご清聴ありがとうございました。
Hi, everybody. I don't know how to say, to dedicate this lecture to Masami Ando. And I like to thank Zaga for really taking this and spread it all around the world. And the lecture will be about life in heaven, because what is important for us is, of course, to respect the people that are friends with us, to respect the people that in the Zaga and people that working with trauma. And Massimi was really one that got to my heart. So I met Massimi in Mykonos with Alex Pivishenko that let me know him on this course lecture. And we become to be friends very fast and quickly. Then I fly to Japan and met both of them, the son, Takuma, and Masami. And it was really a nice journey. We was working together, doing operation with Masami. I learned from him. I saw what he's doing. I learned from him. And really, it was really nice to see this humble and very, very good end and very good brain. And this was really nice to see how it's work and to learn from him. And then, like 3-4 months ago, I find out that Massimi is not in good condition, stage 4. And we try, me, Alex, and some other people, we try really to help him to find some center to cure him. So we sent Takuma a lot of information, but I told them that I come to Japan and I want to see him. And of course, I want to encourage him. I have some conversation with him. And the picture that you see is the day before I met Masami. So I said, before I go to meet Masami, I'm going with his son because Masami was not feeling good. So I go with his son to the clinic and I watch his son doing operation. And it was really like his father, one by one. Nice, clever, fast. I was really happy to see how we do the zygoma cases. And then the next day, we was going to Masami house, but Takuma told me, look, Masami is more than 1 week. He's like on a coma. He's not really respond, so I'm very sorry. My father really want to know that he know that you're coming, but in this 1 week, he's not answering to nobody. And then I say, yes, but anyway, I have to come. I want to pray beside him. I want to talk to him. I want to encourage him. And after this operation, we're going to Masami house. On the left side, you see, I tried to talk to him. I brought him some prayer, but he didn't answer him. So after 10 minutes, I decided that, okay, we don't have what to do, and I will go. And then I told Masami, I'm so happy that I came here. I hope that you hear me, but I will go. And then suddenly, I don't know, like a miracle, Masami opened his eyes, as you see on the right. Everybody was really emotion, even me, very much emotion. He opened his eyes and smiled, as you see here. And even give his hands and shake my hands. And this was really very big emotion for me to see him coming, taking my hands. And then everybody was crying, including me. And then I told him, after this, I told him I will come again. I'm going to do the lecture in Japan, and I'm going to come again to visit you before I fly. And then I go. Then after a day of the course, I came again to his house. And Takuma told me he's still not speaking. He's still in a coma. And then I say, okay, but we will try again. As we tried before, we will try now again. And we will see if he will speak or not speak. And then it was exactly the same. He wake up, he give me his hands, shake his hands, and his son say, Father, he's Ophir here. And then he say, I know. And then I got the book, the Zaga book, that he was so proud of it because he translated to Japan. And because he don't have the power, he signed it with his finger. And this is a good memory because the next day I got a sad message in the morning for his son. So I would like to present a case for the memory of him and for all the people. So this lady is around 70 years old. She coming to my clinic. And as you see, she have an implant before. She don't feel well. She cannot eat. She don't want to go to sinus lift. She don't want to go to big procedure. She just like to go back to life and to really try to hit as possible as she can. So when you look at the CT scan and then you look at the X-ray, you see that on the right side and on the left side we have a lot of resorption, and we don't have enough bone. And of course, we have to extract all what we have here to extract all these teeth and this one. So looking to the CT, so you can see if we start from the left side, we see that the implant is out of the bone. I don't know, I hope that you see my arrow. And then you see that we have a small support of the implant, but the sinus is very low below. And then on the frontal area, we have a lot of defect. If I go to the right side, upper on the right side, you see that is almost the same, very small implant that support very little and not much bone. So for me, especially when even I go to the sinus on the left side, you see here that I have a perforation to the sinus. So it's mean even to do a procedure of sinus lift, when I have this opening, it can be risky. And of course, you know, she need to wait so long time. So we decide to go to Zygoma. I decided in this case to use the guided Zygoma. I can do it freehand, but I want to see the opportunity of the guide that give me more precision and to give me more exact and to make the time operation more short and more safety in this case, because I do a quad on one side and a one on the other side. So I plan it as you see here. So I plan one Zygoma each side as you see here. So I can really plan and to see the prosthetic, to see where is the opening of the prosthetic and to see the possibilities that I have, because this is very easy now. When you have guided, of course, when we do freehands, we do the same procedure to know exactly where we're sitting. So in this case, I can really plan where the implant, as you see here, will be on the bone. I would like to have, of course, bicortical stability and, of course, to engage in the Zygoma to avoid doing sinus lift and doing all of these. So after doing all this procedure, I can print the model, and of course, I can make the operation on the model himself. So this is possible to do. And I do it normally. Now, what is important here when you see this case? So you can see that we have lower and upper. So we do this operation up and lower. But I see here, when you look up, that I don't have enough fixed attach. So it's mean that if you see here in the middle, when I extract the tooth, I make the cutting more palatinally. And I took this gingiva and suture it, as you see here, to the buccal, because I want to achieve as much as more bone tissue, and of course to be supported the bone, because you know what is the complication. I read the book of Aparicio, and I read very carefully where is the problem, where is the failure problem. So I don't want to have exposure of the implant, so I would like to have a lot of tissue. So the cut will be here, and then I suture it. After I suture it, I open the flap. Then you see on the left side, this is my guide. So my guide is supported by screw. First, I have to see that the guide is fitting. I check it on the model, on the printing model before. And as I tell you, I can do the operation on the model. And then I put the guide and fixate it and be sure that it's good. So if you can see here, we do a tuberosity and an implant, of course, the Zaga implant, another implant. So after I put my guide and fixated it very light, as you see, the screw is not closed totally, it's just a little bit closed. I make the mark through the guide where I need to put the implant, because for me, I treat a Zygoma implant like a normal implant. I want to be full of bone. I don't want to have no recession, no resorption. So I treat it like normal implant that have to be supported by bone. When I have the sinus, I will feel a little bit like a ball in the sinus, and I will make the slot technique. I saw it's Alex doing this, and this was very nice. When I was there, I saw how we do it. So I want to do the slot technique. So I do it like this, as you see. I open the window, small one. And this, as you see, this I took from another case because the picture was very nice. So I make the slot here, I open the sinus, the membrane is intact. I'm going down and make a little place to make like a small sinus lift because I want to have a good support. I don't want to have resorption and opening of the implant, so I want to have a good support of bone here too. And I take the bone all around. I go until the base of the zygoma, and if I need to go to orbit, I'm going there, open. Then I take, as you see on the left side, I take a membrane, a collagen membrane, and I fill the membrane and put it from below to upper. This will be the protection for me if I drill, not to tear the membrane when I'm drilling. And then I have a special instrument that I developed for myself that I can really go up and feel that I'm going inside whatever I want. Then I feel, as you see on the left side, all this area with bone, and then I place back the guided. I drill to the guided, and I like to take it out because the guided is not fit for this implant, so I take it out after everything is ready, and I take the Zaga flat, as you see here, and place it all around. For me, it's important that the head of the implant will be a little bit more palatinal, as you see here, because I want to do bone augmentation and I'm afraid of opening here. So 3 BLX, one here, one on the tuberosity. After this, as I told you, I treat it like normal implant. I do bone augmentation. I take the boucher and I suture everything nicely because I have a lot of tissue. And you can see here on the right side that I do some modulation. I take some gingiva from palatinal and put it buccally. Left side, very similar. As you can see, I put the guide, I make the opening, going all around, putting the bone, putting the Zaga flat surface exactly, putting bone augmentation around it, multi-unit abutment, as normal we do. And now I close it. As you see here, I have enough gingiva. It's closed very nice, and the position that I have is a good position. Same, I do lower. BLX implant, as you see here, bone augmentation. For me, I place the BLX implant below the bone, and I take a very long transgingiva because for me it's important the biological width. So even if I have exposure, I can still stabilize the BLX in a very nice way, still fill it with bone, as you see here. And then, as you can see, this is the result what I have. So I have the pterigo, both sides, the Zaga, both sides, BLX, and BLX down. So for me, this is very nice and it's very fast. Everything was very stable and the healing was amazing. So I was very happy to have this case. As you can see here, you can see CT after. And as you can see here, you can see the pterigo is fully on the bone and on the plate because this is very easy for me when I do guided to know exactly where I place it. You can see the implant that I do the slot technique. You see how much bone I have to the sinus and how much bone I have down to the sinus. So for me, this is a very safe. It's very safe because sinusitis, recession, infection, are very well protected. We continue here, and you can watch on the front area how I do the bicortical stability here. So the implant, the BLX, is very strong and very stable. You can see it on the right side, and then you can see the Zaga implant exactly on the left side, exactly with bone augmentation all around it, and then the pterigo. So for me, I treat it like normal implant, and I want to have the best fixation that I can have for here. You can see the lady before and after, and it's really amazing because we talk now about life and heaven, and this is mean to take the girl from life to a life heaven and to give her a change and to give her to feel really good. And then you can see here how she was before and how she was after. And of course, we can do freehand, but because most of our speakers doing freehand, I like to show this opportunity as I show in Spain and another that we can really go for guided. it can help us a little bit. It can help a normal doctor that really don't have the knowledge and they're afraid to come to a more precise. And of course, we can combine both of them. And for me today in a normal practice, mostly I do freehand and I do it under normal anesthesia. But in some cases that I like really to get different and to see this opportunity, I'm going to do it on this one. And because we're talking about life and heaven, I want to give the last 3 minutes of my presentation that for me, this presentation is very emotional because Massimi was really a good friend. Even he was from Japan and I know him for a few years, but I feel that really he's a good friend for me. So this song is by Barbara Streisand, this song called Father, that make me a lot of emotion to hear this song before. And Takuma is this word or this listening is for you. I lost my father 2 years ago and I know what is a loss. And we are all the doctor and the Zaga, we lose Endo, a good friend, a number of friends, a very talented doctor with a lot of idea. So I like to put this song for him, and please listen to the word of the song and take emotion as I take from this song. So here you can see that Masami, yes, I got this from Japan. You can see the closet, and this is from Masami. Listen to the word, it's important.
God, our Heavenly Father. Oh God, and my Father, who's also in heaven, may the light of this flickering candle illuminate the night the way your spirit illuminates my soul. Papa, can you hear me? Papa, can you see me? Papa, can you find me in the night? Papa, are you near me? Papa, can you hear me? Papa, can you help me not be frightened? Looking at the skies, I seem to see a million eyes. Which ones are yours? Where are you now that yesterday has waved goodbye and closed its doors? The night is so much darker, the wind is so much colder, the world I see is so much bigger now that I'm alone. Papa, please forgive me, try to understand me. Papa, don't you know I had no choice? Can you hear me praying? Anything I'm saying, even though the night is filled with voices. I remember everything you taught me, every book I've ever read. Can all the words in all the books help me to face what lies ahead? The trees are so much taller, and I feel so much smaller. The moon is twice as lonely, and the stars are half as bright. Papa, how I love you. Papa, how I need you. Papa, how I miss you. Kissing me good.
emotion for me, especially when after I met Masami the last time, the next morning I get, you see on the left side, a message for Tukuma. And he say, my dad went to heaven on this morning. I think he was waiting for you. This was give me more and more emotion. And with this, I like to say thank you very much. We miss you, Masami. And thank you. Thank you very much. Arigato.
En estos días recibimos la terrible noticia de que nuestro compañero y amigo, el doctor Masami Ando, nos había dejado. La verdad que era una persona con una gran personalidad, un excelente clínico, el Ferrari de los cigomáticos, le decían. Y bueno, te echaremos mucho de menos, Masami. Espero que donde estés bien y te queremos mucho.
There are some people we wish we meet in our lifetime, but just by interacting with them over phone, and one of them for me was Dr. Masami Ando. I had a short chance of interacting with him over a patient of his who visited India, and I had sorted out for him. We pray for his soul to rest in peace and strength for his family, and appreciate Zaga for hosting this webinar in memory of Sensei Masami Ando.
This is Dr. Michael Picos of Zaga Center, Tampa Bay. And I would just like to extend my deepest condolences for the loss of an amazing individual, Dr. Masami Ando. Indeed, his passing has resulted in a huge void for all of us, for his beautiful family, and for us as colleagues. There are not enough words to express truly my sincere sentiments to his family. What I will say, though, is that his memory will live on in all of us, and that we certainly are sharing the grief of his beautiful family as well. Memory eternal.
Dear Masami, it was a great pleasure to get to know you, and also a great honour for me to lecture alongside you at Dentialism out in Gran Canaria. It's with such a great sadness, your loss, and I know that you'll be remembered by all your friends and colleagues around you, and I just wish you to rest in peace, and we won't forget you. Lots of love, Guy McLaren.
I had the honor and the privilege to have met Dr. Masami Ando. We lectured together at the Dentalism seminar in 2023. He came across like a man that knew how to enjoy life. He was a happy man, talented surgeon. The Zaga family has lost a very valuable member. For the Ando family, my deepest condolences.
Hablar de una personalidad, en este caso como el doctor Masami Ando, resulta harto difícil, porque es una persona que vivió, vive y vivirá en nuestros corazones. Tuve el privilegio de conocerlo personalmente en el evento de Canarias y la verdad que es una huella imborrable, un pionero dentro de la implantología cigomática y, repito, es una huella imborrable no solamente para nosotros los colegas, sino para sus pacientes también. Su oficio, su habilidad, no solamente la dejó en el quirófano, sino también la dedicó a formar las nuevas generaciones y realmente es un legado, y precisamente el legado de Masami y nuestro legado es seguir en este caso llevando a cabo la práctica para las futuras generaciones en lo que es el mundo y este campo tan amplio de los implantes cigomáticos.
Hi, this is Daniel from Zaga Center Frankfurt in Germany. I met Masami on the Zaga Summit in Canary Island, and we had a very, very good time together. He's a brilliant surgeon. He's the fastest zygomatic surgeon in the world for sure. And I was totally shocked that he passed away. And if there is a zygomatic heaven, Masami will be in the zygomatic heaven for sure. So rest in peace, Masami.
Dr. Sando, this is a memorial video to you. We dedicate the surgery this day for you.
Greetings from Zaga Center, Athens. This is Costa Nicolopoulos, oral and maxillofacial surgeon. At the Dentulism 2023 conference in the Canary Islands, I had the privilege to meet the great Zygo legend, Dr. Masami. His positive and exuberant character made a great impact on me, and we immediately became friends. My only regret is that I did not meet this great legend earlier in life. I wish his family my sincere sympathies, and I also wish them strength to move forward. I bid Dr. Masami farewell.
Hi guys. It's an honor for me to meet you, Masami. Dr. Masami, he's the fastest Zaga surgeon in the world from Japan.
Yes.
Thank you. It's a pleasure to meet you.
Thank you so much.